Living with the disease obesity. And what are its implications for women's health? Well, a high BMI is common and is a major public health issue in the United Kingdom and in the Western world. Only 1 in 3 of us have a normal weight, but there are specific implications for women. Contraception is a major issue, and a number of studies have been carried out, but all have particular flaws, making interpretation extremely difficult. One of the more reliable studies demonstrated that if you have a BMI over 32, then the risk of pregnancy is doubled. This sounds alarming, but this is the doubling of a very small risk, i.e., if 100 women with a BMI at more than 32 use the combined oral contraceptive pill for 1 year, an extra 2 to 4 would become pregnant. The Royal College of Obstetricians and Gynecologists, though, recommend women using the progestin-only pill use 2 pills per day if your weight, note not your BMI, is over 70 kilos. However, this advice does not apply if you're over 45 and your natural fertility has reduced, or you're using Cerazette. Some may be using a transdermal estrogen and progesterone contraceptive patch. This is less effective in women over 90 kilograms, with 5 out of 15 becoming pregnant. At the moment, EVRA advises caution in any woman overweight using this as a method of contraception. It is confusing. High body weight has been associated with increasing probability of luteal activity and a higher failure rate in vaginal ring users, but also is associated with fertility difficulties. The combined contraceptive vaginal ring study showed that at the end of 1 year, 100 women weighing 40 kilograms could expect 2 pregnancies, but this increases to 8 for those who weigh over 70 kilos. Essentially, a drug dose is dependent on the weight of a person. In the same way we reduce a dose for a child, do we need to increase it for a heavy adult? All drugs are designed to produce a blood level, which is expected to be above a level at which the drug will be effective. This is not a problem if the blood level is always above the therapeutic level, but if for some reason the blood level isn't reached or it falls below the therapeutic level, this may be a problem for some as the drug stops working. If you're trying to lose weight, you naturally will be concerned if taking the contraceptive pill is going to make you gain weight. Pill compliance can be dependent on the level of concern women have and how they feel about perceived or actual weight gain. In theory, estrogen can stimulate the renin-angiotensin system in the kidney, and this can cause fluid retention. Particularly, you may find that your ankles or wrists start to swell. Some women may find that it increases subcutaneous fat, particularly around the breasts, hips, and thighs, as a result of the estrogen receptors there. The progestions may also increase the appetite due to their anabolic properties. However, no large effect on weight has been found, but these studies have been subject to bias. There are other methods of contraception and they may also have implications. What about combination skin patches and weight gain? There's no known data about this and whether it has an impact. Combined contraceptive vaginal rings? There's no suggestion that your weight will increase, but then there is no data. What about the different combined oral contraceptive pills? Often your doctor will suggest that you try a number of contraceptive pills until you get one that's right for you. What they have found is that those with ethinyl estradiol with drospirenone experience weight loss compared with pills with ethyl estradiol and levonorgestrel. The progestogen drospirenone is what's called an anti-mineralocorticoid. It's found in yasmin, and it may counteract the edema-producing effects of estrogens and initiate a diuresis. That is, it will cause you to pass more urine and reduce the amount of sodium and water retention. You may have a friend who's actually lost weight taking the combined contraceptive pill. Is this true? Well, there was one study that showed that body adiposity was reduced when polycystic ovarian disease women who were also taking flutamide and metformin with a BMI under 30 used yasmin rather than a gestodine-based combined oral contraceptive pill. They experienced a reduction in total fat of 0.8 kilograms, and particularly abdominal fat was reduced by 0.5 kilograms. Many women associate Depo-Provera with weight gain, thinking it's due to the appetite stimulant effect of this progestogen. Is this true? Well, there is conflicting evidence about this, but let's say for 5 years there are two groups, that one uses Depo-Provera or the copper IUCD. You would expect to find at the end of that 5-year period, those using Depo-Provera have gained about 4.3 kilograms compared with those using the copper coil would only have gained 1.8 kilograms. A baseline BMI is a predictor of weight gain with Depo-Provera use, and overweight adolescent girls have a significant weight gain during the first year of using Depo-Provera, which you would not see with the combined oral contraceptive pill. However, you have to bear in mind that not all women can use the combined oral contraceptive pill, whereas most women can use Depo-Provera. Perceived weight gain is a frequently reported adverse effect in implant users. This typically applies to Norplant and Implanon contraceptive systems. Studies have shown that after 2 years, 60% of women will gain 1 kilogram and 40% may have gained 3 kilos. And 42% of implants have been removed due to weight gain. The good news, again, is that Mirena IUCD shows no clinical evidence of weight gain and seems to be a good alternative. There is a risk of venous thromboembolism. That's where you have in one of the veins, you develop a clot, and there is a risk this clot can be detached and lodge elsewhere in the body. Sometimes this can have very serious effects. Now, if your BMI is more than 30, there is an increased risk of venous thromboembolism. And if you're taking the combined oral contraceptive pill, there's also an increased risk, but the risk is 25 per 100,000, so it's actually very small. Some have asked, well, what is the absolute risk attributed to the combined oral contraceptive pill if you're overweight? And others have asked, is there really no evidence that the progesterone-only pill will increase your thromboembolic risk? The answer to these questions is simple. The progesterone-only pill has no effect on your risk of thromboembolism. However, there is an overall increased risk of women who are overweight using the combined pill. The Faculty of Family Planning and Reproductive Health advise that you should use a combined contraceptive pill with caution, and you should have an informed discussion about the risks. They're not saying you shouldn't use it at all, but your doctor must discuss the risks with you. The BNF flatly recommends that women with a BMI over 39 should not use the combined contraceptive pill, particularly when suitable safer alternatives exist, such as the Mirena, Implanon, or the progesterone-only pill. As well as getting disease in the veins, you can also experience disease in the arteries. And being overweight is an independent risk factor for arterial disease and is associated with worsening of your cardiovascular risk profile. If you have a high BMI, then there's double the risk of a heart attack, particularly if you're using the combined contraceptive pill. But please bear in mind that the risk of a heart attack is very small anyway. This risk is 2.5 times for levonorgestrel pill and 1.3 times for destrogel and gestodine users. There's also a small increased risk of subarachnoid hemorrhage attributed to the combined contraceptive pill. But obesity per se makes no difference. Body weight changes in HRT. As a woman increases in maturity, her needs switch from contraception to perhaps considering hormone replacement therapy. Body mass index increases as a function of age. And as we increase in age, we increase our body mass index, but the menopause appears to make no difference to the rate of this change. What has been noticed is that menopausal hormone changes are associated with truncal and central android fat distribution. So you change your shape from being like a pear to an apple. Visceral adiposity has an increased risk of coronary artery disease, particularly if above 106 centimeters, and this jumps dramatically if above 163 centimeters. Sadly, many women decline HRT due to a fear of weight gain and the preoccupation with body image. But there's little evidence to substantiate this. There have been studies which show no difference to weight with any oral HRT. Some have reported that HRT will promote a gynecoid fat distribution, but there's no evidence it will redistribute any of the body fat. The total body weight increased with transdermal HRT users, but hasn't decreased with women using oral regimes. And there's no significant weight change using tibolone. A big question is what effects does HRT and obesity have on cardiovascular disease? Well, we know that having a high BMI and living with obesity increases your risk of cardiovascular disease. Unfortunately, there's no evidence to suggest that HRT has a beneficial effect on your cardiovascular health. There is a risk of venous thromboembolism, as you'd expect with an increase in age, and HRT results in a threefold increase in risk in obese women and an increase of 4.6 of venous thromboembolism. But bear in mind, this is a small risk that's been multiplied. Some women describe breakthrough and irregular bleeding, but this is not associated with a high BMI, and that you should not be at more risk of this if you are overweight.